today's vertical integration session, Sexual Violence, the Whole Practice Approach with Dr. Alison Lancy and with DFSV linker Leanne Fletcher. Now, my name is Sydney and I'm from the PHN Education team. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself on the Central Coast, that is Darkinjin land, and I'd also like to pay respect to all elders past, present, and emerging. Now, a few things to let you know about this session. It is being recorded and will be available for you to view in our library, along with a copy of the PowerPoint PDF presentation slides. As attendees, you have access to your camera and microphone. We do ask that you mute yourself for the presentation. And if you have any questions throughout, just pop them in the chat, and then we'll have a casual chat at the end as well. At the end, I will put in the QR code and the Slido link for our evaluation. Now, your feedback is important to us as we provide it to the presenters, as well as it enables us to provide future education. I will now hand over to Dr. Alison Lancy.
Good morning, everyone. Thank you very much for allowing me to come and talk to you about the program that we've been running. So I'm a GP based in Newcastle, and I've been working with the Primary Health Network for the last 2 and a bit years with their domestic family and sexual violence program. And I'm really, really excited to talk to you about the work that we've been doing and to introduce you to your linker for the Central Coast, and in terms of what that role means and when you might refer. But we're going to talk more broadly about sexual violence and how it might present in general practice and what to do as well. Now, there's a QR code on the front screen. If you can scan that for me, that would be great. That is our official kind of evaluation that goes to the Sachs Institute about this program. This program is only funded for another 12 months, and then we know how valuable the program is, but we kind of need that data for the government. So if you wouldn't mind scanning that and filling that out at some point, that would be amazing for us, because yeah, we're doing our best to continue the program as much as we can. Make sure I can. So I would also like to acknowledge the traditional owners and custodians of the lands that we're living and working on as in the first people of this country. And I'd like to acknowledge the huge amount of work that has come from First Nations people in this space around sexual violence, around domestic and family violence. There's just so much wealth of knowledge and experience, and I would like to acknowledge that all of that comes with this presentation as well. So as we get started, I am really strict on this around the use of Safe Talk. This is something that I learnt from an organisation called Full Stop Australia, which I have a video from them in a moment. The whole point of this session is for you to leave feeling like, this is not so scary. I would know what to do if someone disclosed to me. I would know what to say. I would know where to get help. I know what to do. And I am very much of the belief that this information is relevant for clinicians, nurses, admin staff, just anyone that will listen, to be honest, because unfortunately sexual violence is so prevalent in our Australian society, and it affects an awful high number of people. And because of that, if there's at any point where you feel like this is confronting or the discussion is like bringing up feelings for you, please take a break if you do need to do so. But I am very cognizant, if I talk about cases, I don't use a lot of detail for that reason. I don't want this to be a difficult discussion. I want you guys to leave feeling good at the end of it. So the learning objectives for today are around how do you recognise and respond to disclosed or suspected sexual violence, and we talk a lot about the sort of trauma-informed or whole person care, because this is kind of like the bedrock of, I think, everything we do in general practice. So I will be talking around those principles as well. And then the other really important thing is about understanding the local referral pathways, and what specialised supports are available. And then the long-term goal is around you guys in practice feeling more confident, responding well, and by doing that, you will contribute to improve short and long-term health outcomes for victim survivors of sexual violence. And in fact, that the way that when someone first discloses, and we'll talk more about this in a few slides, but if someone does disclose that they've been a victim of sexual violence, that first disclosure is like has the potential to change the entire trajectory of their health, essentially. And so by responding in a really trauma-informed and a really fantastic way, which I know most of you do in your practice, but just the right choice of words can have a huge, huge impact for people in the long term. That content, we can talk a little bit about definition. I am very much of the belief that we need to do some myth busting, I think, around sexual violence in Australia. And I found this amazing article when I was developing these slides from the Australian Criminal Institute around how the pervasive myths around sexual violence, and you can probably already kind of hear various things. And I was reading an article yesterday about a current court case that's happening. These kind of pervasive myths in society, and because they're so pervasive in our society, they do affect court cases. They affect juries' understanding of someone's response, and so I want to do some of that improving our understanding, so that if someone does say something like that to you because it's so pervasive, that you'll actually have the words to be able to challenge that too. And then our primary care response is around how do we spot the signs that someone might have experienced sexual violence. How do we create safety for someone to disclose? And that's all our trauma-informed care stuff that we're going to talk about. And then what do I do? How do I create safety in that disclosure, in that space? How do I respond safely to that person? And then how do I link them for support? And we'll do a little bit about like recording because there is some really important legal components as part of that, which I want to cover as well. And then a little bit of self-care at the end. So please, unfortunately, I can't see the chat today. But if you want to put anything in the chat at any point or ask a question, please do so. If you don't have access to the chat, I'm very happy for you to unmute and ask a question. And Leanne and Georgia will jump in and stop me at any point. So Georgia, I don't know if you can monitor the chat for me, but I'm really, really keen if people are happy to just type in a couple of things about what's really great about where you work, your practice. Something that you really love from your perspective, or something that you think is really great, like from a patient coming into your practice, like why would a patient think your practice is great? So I don't know, Georgia, if you're able to just read out a couple of things from the chat for me.
Yeah, no, I can monitor the mute. And for our practice, I think our practice has got a nice we've got a nice waiting room with a nice homely environment. It doesn't look too clinical. So it's a safe, relaxing place is what patients say. They go, it's so nice out here. Your practice is so nice. So it's the vibe.
The vibe of it. I love it. And that's like a really, really important thing. And we're going to talk about that like in terms of how do you create safety. And it's about your waiting room, what's safe about your waiting room, and why does it feel like that? Whether it's not because it doesn't feel clinical, because you've got like an acknowledgement of country on the wall, or you've got Aboriginal art, or you've got rainbow flag and the Aboriginal flag and the Torres Strait Islander flag. Like, all those little things do create safety for someone in a waiting room. But yeah, that's a really, really interesting, like great point about that. I don't know if there's anything else that's come through.
Yes, we've got Alicia says, yeah, fantastic staff. Patients love that they feel important from the welcome from administration.
Yeah.
So I think that really friendly and welcoming administration staff is very important.
Yeah, and another safety component as well. It's like how easy it was easy to get an appointment or to make an appointment, and the staff were so welcoming, and they made me feel so like relaxed, even though I'm stressed about being at the doctor. Like all those things are amazing. That's awesome.
And Elle mentions that her practice is quite small and old, but patients know that it's like a family setting. So I can imagine that the staff would know the patients really well. So it's almost like family.
Yeah, and that's it. Another thing, like if you've got amazing staff and you communicate well as a staff within a practice, the patient kind of knows that if there's an issue that they're going to be looked after. All of those things that makes what's great about staff. Fabulous. I love that. So these are two things that I want you to think about now, because we're going to come back to it later on. So you don't have to share, but just think about it. So if you can just reflect for a moment, what makes you feel safe? Like, have you got a space that you always know, I feel safe, I feel at home here? Or have you got a person in your life that you know is your safe person? Like you can always go to them whenever anything is happening, and you can always tell them the truth, and you know that it's going to be okay. So I'm really keen for you guys to reflect just yourselves about what is it that makes me feel safe around somebody else or in a space? Because all of that is going to come back to our trauma-informed care principles in a moment. So let's move on. Let's talk about definitions. So like domestic and family violence is a big umbrella term for a lot of different behaviours. Sexual violence is the term that we use to cover a whole range of behaviours around sexual contact and various things. So you can see a bunch of stuff on the screen. And basically sexual violence includes contact behaviours. So that might be rape, sexual assault, penetration, any kind of forced touching or any kind of where someone has laid hands on another person, essentially. So that's kind of our contact behaviours. But it also includes what we would describe as non-contact behaviours, which you can see on there, like forcing someone to watch pornography against their will, image-based sexual abuse. So that's if, you send an intimate photo to somebody, and that's your choice to do that, and then they upload it online or they do something without your consent. That covers things like revenge porn, AI-generated pornography. I'm not sure if you've had any schools on the Central Coast where that's been an issue, but we've had 2 in Newcastle where that has been an issue. And it's frighteningly easy to do that, to take someone's photo, just a standard photo from their Facebook page that you've taken of them, and to plug that into programs online and generate AI pornography of that person. And so we are seeing that quite a lot in the community at the moment. It's being handled very poorly by schools, unfortunately. And things like indecent exposure, all of those kinds of things. So I don't know if anyone has got any questions about any of the words that are on the screen. Sometimes I get asked what stealthing is, and that's if you've asked someone to wear a condom and then they take that condom off during sex without your awareness. Even things like reproductive coercion and sexual violence is often very strongly linked with domestic and family violence as well. So it basically is when someone's coerced, manipulated, forced, uninformed, or unable to consent to a sexual act. So you can see that it covers an awful lot of things. And at the heart of it, doesn't matter if it's like a contact behavior or a non-contact behavior, all of these things cause harm. And they cause the same amount of harm for the person that experiences it. And I think that's a really, really important point, that it doesn't matter what the type of sexual violence is that occurs for that person, the long-term effects are the same for that person in terms of their mental health, their physical health, and their well-being. So all forms of sexual violence cause harm for a patient. Now, I do have a video that I'm just going to share because I think it's really important to hear from victim survivors of sexual violence. This does talk a little bit about child abuse and domestic family violence as well, but there's a couple of interesting things that people say in this video that I'm really interested for people to pop in the chat as you're watching the video. If something really jumps out at you, please pop it in the chat to share, because I think there's some interesting discussion. So I'm not going to play all the video, but I will play a little bit of it.
It takes such a long while to come to terms with things, particularly when it's abuse that happened since you were a child. You don't know any other reality.
No one should have to experience violence of any kind.
I went through a massive amount of victim blaming. Things like, why didn't you fight harder? Where were you? What were you wearing?
I know for a fact if I saw a man in the media talking about what I'm talking about now, that could have saved my life. So I could be for the little boy today what I needed at the time.
I was told by my perpetrator that these incidents of unwanted sexual contact and sexual touching in the lead up to an attempted rape were my fault, and they were only happening because it was my idea. And the fact that I'd had a freeze response meant that I must actually want it.
Every profession should be safe. And there's no difference whether I've been sexually assaulted as a waitress, working at the office, or as a sex worker. It should have never happened. autistic, ADHD and dyslexic. Before my diagnosis, it was really easy for someone to convince me that they pushed me because they are my friend, or this is happening to me because they are nice, and that it's actually me who is doing something wrong, and that I am impolite.
I think we need to recognize that women and girls throughout their lifespan, from birth to death, are vulnerable to sexual assaults. There are 50 sexual assaults taking place in aged care in Australia every week. Nobody believes them. Nobody believes that older women in aged care can be sexually assaulted because they're not seen as sexual beings.
I felt that I didn't stand a chance. My parents wanted for me to have an arranged marriage. You know, the word sex was never said.
I remember sobbing really hard and going to the room where my parents are sleeping, and they were asking me so many questions, but I wasn't coherent, and all I wanted was my... She seemed, I guess it might be intergenerational trauma, but she seemed like she couldn't really do it, so I physically took her arms and put it around me to try and feel better.
I also wish, as a child, that someone noticed any of the signs of a child going through abuse, and I wish that someone called the police or called Child Protection Services.
Talking with the Full Stop Helpline has been such a life-saving thing.
Flood society with help. There should be more centres for therapy than there are McDonald's. You know where to get a cheeseburger, but you don't know where to get help, you know.
I'll stop the video there. But I don't know if anything is going into the chat. There's anything in the chat, about anything that jumped out at people?
There's a great question, Alison, from Samantha. She's asking, because you mentioned poorly managed by schools with the AI porn. How would we advise a student parent to approach the school in a situation of digital sexual violence, AI or otherwise? What should they ask for specifically, and are there any resources for schools?
That's a really, really great question.
Yeah, it sure is.
And probably out of the scope of everything, because we could probably spend the next 40 minutes talking about that. What I will tell you is that the eSafety Commissioner has a whole page on that, and that I would have a look at, because it has specific fact sheets for parents and for people who are experiencing it. And it talks about how you can get that taken down off the internet and how you can report it as well. I mean, from a school perspective, AI-generated pornography, if someone's under the age of 16 or even 18, it's child sexual abuse. That's what it comes under. So it's a crime. So I guess thinking about it in those terms, and also like talking to the school about what they're planning to do. If you're talking to the parent, talking to them about whether they will go to the police or not. But this is like where your link can come in as well, because the whole point is for them to be able to support family. But also when we've spoken to the sexual assault service at the hospital, like they're very keen for anything that's kind of under the age of 18 for you to talk to them and get advice through them, because they have specialist social workers, they've got additional supports and that they can link young people in with to make sure that they're okay, and they can have a lot of these discussions as well. So I know that was kind of a bit of a varied response, but I wouldn't be having these in-depth discussions telling parents what to do, all that kind of thing. I think that's outside the scope of general practice, other than the eSafety Commissioner has some information. Can I make a referral to our local sexual assault service, because they'll talk to Child Protection, they will have the social workers, they can provide ongoing support for that young person. And in terms of the school, that's outside of the scope of what I would say, but it's making sure that there's a report made to the Child Wellbeing Unit or to DCJ about the person that's affected, and potentially about the person who's like uploaded the pornography, because that's like harmful sexual behavior as well. So there's kind of multiple factors, and it's complicated, and get advice would be my biggest thing. So don't just kind of go off your back and say a whole bunch of stuff. I would be talking to the sexual assault service, the clinician during the day, 9 to 5. There's always someone that can provide advice to general practice. And they usually have it's either a clinical nurse or some consultant that is on during the day that can give you that advice, and they can organise for that young person to be followed up. So sorry, that was very long-winded. I hope that was answered the question. Is there anything that jumped out from the video? I can't hear anyone. Have I lost people? Everybody's frozen.
I can hear you, if that helps.
Okay. I feel like everybody else is frozen.
Yeah, I've got you as well, Al, but your screen stopped.
Okay. Oh, okay. I'll just reshare again. I don't know what's happened. The internet is. So I hope that answered the question. Yeah, so I can see in the chat, yeah, the aged care, that's a big concern, isn't it? And quite a shocking kind of statistic that came out from the Royal Commission into aged care a couple of years ago.
In the chat, sorry, Alison, but in the chat, another stat, 50 women in nursing homes assaulted a week, question mark. Is that correct?
Yes, that is correct.
It's
so that came out of the Royal Commission. Yeah, it came out of the Royal Commission into aged care a couple of years ago. So that's an ongoing statistic. And so, yeah, again, frightening, very frightening. I find quite interesting in that video the young woman that talks about how before she had the diagnosis of ADHD and that she found it was very easy for other people to manipulate her. And I think that's really important, that vulnerability, particularly people experiencing any other kind of intellectual disability. There's very high risks of sexual violence against those people as well, and anyone that's got a disability or got some social vulnerabilities as well. Can everyone see my slides? I feel like I'm dropping in and out.
Yeah, we've got you.
So why is all of this important? So unfortunately, about 22% of women and about 6% of men will experience sexual violence. And the other really big statistic is about 92% of women who experience sexual violence from a male will not report that to police. So the data that we have is very high anyway, but that's only reported violence. And we know that that's only 8% of the full story. So I think what you will probably see in general practice is a lot of people that will come and disclose to you, but then they will never report that to police. That data is never going to be recorded, I guess, if that makes sense, but you're going to hear about it, which is why this training is so important. In terms of who's at risk, so these are kind of the groups of people that have much higher rates of sexual violence against them. So girls aged 10 to 17, that is the highest age group that are likely to experience sexual violence. So this is where, we're so well placed in general practice. We're already having these discussions with young women and teenagers when we're starting, talking about their health, talking about starting contraception, talking about starting having sex, all that kind of stuff. So we're really well versed in having these conversations. And I think, talking about consent, talking about this kind of stuff with young people is what we do really well in general practice, and what I would strongly encourage to be kind of becoming norm. Like I said, people with disabilities and particularly intellectual disabilities, that's a very, very high rates of sexual violence. Women experiencing homelessness, if you're experiencing other forms of domestic and family violence, migrant refugee or called background, First Nations women, sex workers, women aged care, the LGBTQIA+ communities, unfortunately, really high rates there. And if you've previously experienced sexual violence. So these are the kind of higher risk groups, I guess. and where we're likely to see sort of higher than average rates compared to the rest of the population. Now, I really like to talk about what the law is in Australia. We have what's called affirmative consent laws in New South Wales, and that's from a very high profile case. Like that was changed a couple of years ago from a very high profile case where a young woman was sexually assaulted on a night out, and she had a freeze response. And at the time, the law kind of said, well, she didn't say no, and she didn't kind of fight back. So how was he to know that she didn't want to have sex with him? And so like he got off. It was very, very high profile at the time. But as a result of that, we now have affirmative consent laws. So that means that you have to actually say, I want to have sex with you. It has to be free and voluntary, clearly and enthusiastically communicated. It's ongoing and it's specific. Now, by that I mean, just because you consented to one kind of part of sex or kissing or taking shirt off or whatever it is, because you've consented to that part, it doesn't mean that you consented to everything else. Just because you've consented to, having sex in one particular way, it doesn't mean that you've consented to multiple different types of sex or in an ongoing way whenever that person wants to have sex. So that's what sexual consent is. And you will, there will be people that talk about, particularly with domestic family violence, like sex on a schedule. No, I didn't really want to have sex, but like he really wanted it, and we're married, and like what, like that's not consent. Like that's being badgered into having sex. So I think it's having that understanding about what consent is, and you can be having these conversations with young people, particularly young men and young women that you're seeing about. Do you understand what the consent laws in Australia? Because I think that there's still this kind of myth of like, and this internalized myth for people who experience violence that, well, I guess I put myself in the situation, or I led them to believe that I wanted to have it. So like there's still that kind of ongoing, self kind of blame that occurs, but this is what the law states. And the other big thing is sexual consent can be withdrawn at any time. And so that website, that Make No Doubt website with New South Wales Government has some really good videos for young people and flyers and stuff like that. So that's a really good one to have a look at as well. I don't know if anyone has seen the Tea and Consent video, and I really like that and the whole concept of that is a lovely little animation, and it's basically stating, if someone comes over to your house and you go, would you like a cup of tea? And with tea being sex in this case, not that that's what happens when I invite people over my house, but anyway, would you like a cup of tea? No, I don't feel like a cup of tea. You then don't pour tea down that person's throat. So they've said no. And so that's kind of what the idea of this video is. And it's very well done. And I think it's quite good. There's another little video done by the same people that I might send to Sydney to send out to you guys to have a look at, that's around actually body language. And so I think that one is a really great one for young people, because it's kind of like when yes actually means no, and this whole idea of like, well, it's a yeah, but it's not an enthusiastic yes, or so that kind of thing. So I'll send those videos for Sydney to put out for you guys, because I think they're really worthwhile watching. Any questions up until now? Sometimes I feel like I'm talking to the ether. Is everyone still there?
Yeah, we're still here. No questions.
Oh, good.
Yeah.
Normally I have like multiple screens and I can see everyone, but I can't today. So as I was talking about before, I found this amazing article when I was developing this talk around the pervasive myths in society, and I was like, this is something that I want to go through. I want it to be included in the training, and certainly, victim survivors. This is like we internalize these myths as well within our work, and victim survivors do the same thing as well. And so I think it's really important to kind of have this understanding. So I'll work through it. Please stop me at any point if you've got questions. The biggest thing is that people in almost all cases will delay the disclosure of sexual violence, or they may never disclose. It can be 5, 10, 20 years before someone discloses that they experience sexual violence. The average for people that experience child sexual abuse is something like 25 years it takes them before they will disclose that that occurred. So the delay in the disclosure is very, very, very common. Unfortunately, the myth is that if you really experience this, you would tell someone immediately, which we know is not the case. The majority of victim survivors will delay the disclosure. And women, men, and non-binary people of any age can be affected, as we were saying in that video. Women in aged care, older women are just as susceptible to sexual violence as younger women. And men as well, as we saw from the statistics. This is the age group. So about 42% of sexual violence that occurs in Australian society is targeted at age 10 to 17-year-old girls. So that's our highest kind of victim survivor kind of age group, which is a horrifying statistic, to be honest. And unfortunately, that, people are targeted because of some kind of perceived vulnerability, whether it's social vulnerability, their health condition, a disability, something about that person is often why the perpetrator will target them. Now, leaning into that, I think everyone at any age across, all society can be potentially a victim or, at some point in their life, depending on that vulnerability. So nobody, I guess, is kind of immune to this, but there are certainly groups which we talked about before that there's just that higher risk. And it's the same with domestic family violence, where there's that risk of someone being isolated, discriminated against, or not believed for whatever reason, then that does increase their vulnerability to experiencing sexual violence. And in terms of how someone responds, so how does someone respond to experiencing sexual violence? The biggest one, and this is the court case that I was reading yesterday in the news, is the biggest thing is that false allegations are rare, extremely rare. And so in the court case I was reading today, the whole defense thing is built around, it was just, the person had regrets, and so that's why they brought this false claim. False claims are extremely rare. It's less than 5% of all kind of allegations would be false. And within that 5%, particularly for women that make those allegations, if it does turn out to be false, it's generally not from malice. It's generally because of fear, because of basically that person is seeking help. So that kind of argument of it was just bad sex, or they just regretted it later and they were ashamed or whatever, and so they decided to, to target that person, and they're just bringing this person's reputation down. Isn't it terrible? That is extremely that is just a complete myth. So I want to make that really, really clear that if someone does disclose to you, you should always believe them because the false allegations are rare. And it's a really common response to freeze. So I'm hopeful that you guys have heard, that whole idea of that fight or flight reaction, and the idea of freezing. And it's a really common response for people, which is why we have affirmative consent laws now in New South Wales. It's a really common response for people to be like, I am very uncomfortable with this. I don't know what to do. I don't feel safe anymore. I'm just gonna, and I can't move, and I can't. And so that freeze response is really, really common. It does not indicate consent at all. And the other response that occasionally occurs is this kind of fawn response, which we often see in domestic and family violence, where that the person is the internal monologue, I guess, is, I don't feel safe here. I'm going to do everything to kind of flatter this person and make them feel good because I just want this to be over, or I want this to go away, or because I don't feel safe. They're basically learned responses in order to self-protect. And I guess the kind of myth is that, well, if it was real, if someone was doing something to you that you didn't like, you would have fought back. You would have said no. You would have made it clear that and that's just not the case. The most common response is to freeze. And this whole thing, and you guys would see this in practice, emotional responses of victim survivors will vary. someone might be very distressed at one point in time and they might be really disassociated at another point in time, able to describe to you the most terrible thing that happened to them in a really calm, collected way. And we as clinicians are also really good at this. We're really good at walking into the hospital, walking in and hearing really distressing things and keeping this really calm demeanor, talking about really difficult things with like no kind of emotional engagement in a lot of cases. We've trained ourselves to do this really well. So victim survivors are also trained to do this really well. And that emotional response will vary and it changes, and it might not fit with what you think somehow someone should respond. And the myth here is that, well, if it really happened, they would be distressed. They'd be crying, they'd be upset, that this person's not distressed enough. But it's just completely not true. Their emotional response is there to protect you. So it can vary, and it can be like long time after the fact where someone finally has that really distressed response potentially. And a lot of that time it's just around safety. It's not safe to be emotional. It's not safe to kind of feel it, to let your body experience that. And so that disassociate, that kind of shut down, a very cold emotional response is most likely the protective response in some cases. And this idea of memory is not linear after trauma. People ask me, what did you do on the weekend? And I have to sit and think for like 20 seconds before I can remember what I did and in what order I did it. And that's not me experiencing trauma at my weekend. That's just my memory at the moment, because I've got so much going on. And I think that's really important to just, if someone does disclose, you don't need to document a kind of linear history of what happened. Just document what they tell you. Memory comes back to people in bits and pieces. And so, you don't need this kind of coherent, A to B kind of story that you need to document from somebody. Just document whatever they tell you. And in terms of perpetrators, I think it's really important for us to understand who the perpetrators are and what is going on. It's most likely the perpetrator is going to have a prior relationship with the victim. They're going to be a partner, a friend, carer, somebody in that person's social sphere. And most sexual violence occurs in the home as well. It's not on a night out down a dark alley. Those tend to be, they do happen, absolutely, but they're not the most common forms of sexual violence that occur. And unfortunately, the highest age of perpetrator group is this males age 15 to 19. So we've got the highest age victim, the group that's the most likely going to be victims, and the people most likely to be perpetrators are in the same age group. So I think, again, in general practice, we're seeing these age groups. We can be having these discussions at an early age. And I think the schools need to be really pushing that consent, education with these young people as well, because we're just seeing these two age groups are the highest risk groups. And finally, this was a study that came out last year around getting people to self-report if they had perpetrated sexual violence and against someone else. So this is an Australian study. And so this was self-reported. So I think the data is actually fairly accurate. And it ranged from, just bugging somebody to get their phone number, or to to kiss them, or inappropriate touching. It kind of went from that spectrum right through to sexual assault and rape. And this was what they said, that about 1 in 5 Australians said that they had perpetrated some form of sexual violence. And that was men and women as well. So I thought that was just a little interesting one, that unfortunately, same with domestic violence, we're going to be seeing victim survivors, but we also see perpetrators in our practice as well. And that's another kind of nugget of work that we're working on in the primary health care to provide education for you guys in the future. So I don't know if there's any questions or any of that, and I've raced through it all. I don't know if anyone's got any comments. Interested. Again,
Can I just add, Alison? Also, I've supported people who have had no memory really of historical childhood sexual assault until they're or even if have slight memories and put them away until, say, their child's become that age of when it happened to them, then it really triggers them.
Yes,
Yeah.
and that's such a
Yeah.
big thing, like with memory, like, and we're so good at protecting ourselves that you can box that up until, for your own safety, and lock it away and not remember until, like, exactly like you said, that there's some sort of trigger, the age group, that you've got a child or a grandchild, or there's something in the news or whatever it is, particularly for child sexual abuse. But yeah, that's a really great point. Thanks, Leanne. So, how are we going for time? I might skip this little bit because I want to get through. In terms of spotting the signs of sexual violence, often it's not what you see in general practice is not going to be what they're going to see at the sexual assault service at the hospital. You're going to see somebody weeks, months, years down the track, and so you're not kind of going to see that kind of classic signs of post-sexual violence, I guess, if that makes sense. And like I was saying before, that a lot of the sexual violence is non-contact behavior as well. So mental health tends to be the big kind of sign. So any kind of patient that's got a lot of fear, anger, self-blame, the shame, that's like the pervasive thing that continues for most people that experience sexual violence. PTSD, any kind of substance abuse, complex trauma, self-harm, suicide ideation, eating disorders, sleep, anxiety, depression, like all of the mental health stuff, basically. For anyone presenting with mental health, we would always strongly encourage that you should be screening for domestic and family violence, and sexual violence would be part of that as well. It's just really, for people that are experiencing any kind of mental health, the rates of them experiencing or having experienced DV, sexual violence or child sexual abuse, are really, really high. And so it should be part of your thinking when you're doing those initial assessments with people. And medical things as well can be kind of give you clues as well. So men tend to present to general practice with either sexual dysfunction or concern around their sexuality. So that tends to be a more frequent presentation for men who've experienced sexual violence. For women, it can be recurrent, UTIs, STIs, but chronic pain tends to be a really big red flag, particularly chronic pelvic pain. Or is someone that's really concerned about, preventive screenings, cervical screening, ongoing kind of poor physical health, ongoing, mental health concerns. All of those kind of things can be little flags in your brain that maybe something else is going on for that person or has happened for that person in the past. So I guess a lot of our work in general practice is about how we create safety for someone to tell us the most difficult things that are going on in their life. And we see it day to day. And we talked a bit about safety, and that safety starts when someone enters your waiting room, the interactions they have with your staff. That's why I love coming into practices and doing this training with everyone in the practice, because your admin, your allied health, your nursing staff are all like a big part of how we create safety for patients and how patients feel safe. But it also comes into things around asking you, the clinician, asking for consent when you're doing physical examinations. Is it okay if I touch you in certain spots? And this is the reason why I'm going to. I need to listen to your chest. Is it all right if you lift up your shirt so I can listen to your chest, so I can listen to your lungs? Explaining why, that informed consent doesn't just extend to procedures. It also extends to investigations and examinations for patients. So particularly people who've experienced domestic sexual violence. How trustworthy is your practice? Have you got great policies for confidentiality, for managing information? Do your patients really understand if you're using AI, for your documentation, what that means? All those kinds of things. Like, do your patients trust you, the clinician, trust your practice? And do you offer choice? So all of these things are principles around trauma-informed care and from the Blue Knot Foundation. And this is just around, okay, so these are our options, what's important to you right now. Offering that choice, because most people who've experienced domestic family and sexual violence have had that choice taken from them. So by you offering choice and by you just not telling them what they have to do, you're creating additional safety for them. And that flows on with that collaboration, that validation of somebody's strengths, and recognizing that someone's background is not the person that they are. And acknowledging their strengths. I know this really terrible thing happened to you. So you're a really strong person. You look at these other things that you've achieved. Let's work on these strengths and let's go from there. So all of those things are around how we create safety. And if anyone out there has ever had someone disclose to them that they're a patient disclose, or a friend or family member disclose that they've experienced sexual violence, they've experienced domestic family abuse, amazing. You've done an amazing job. You created safety and you validated that person and you were a good person, and that they felt like they could disclose that to you. And it's amazing. I think we need to celebrate our strengths as well in general practice. So, in the interest of time, if you can pop in the chat for me. So thinking back to the start, that question I asked you, what would make somebody safe for you? What makes someone a tellable person? Why would you go to a particular person and tell them all your deepest, darkest secrets? What is it about them? What do they make you feel? I'm really just a couple of quick things from anyone, or if Georgia or Leanne want to jump in, and I'm very, very keen to what people think.
I just mentioned, Alison, Gordon's put in the chat, I love it when my admin team notice things when a patient calls up or when they check in at front desk. It gives him a heads up.
It's so good, isn't it? The reception staff are your eyes and ears of the practice. They see what's happening in the waiting room. They know your patients in most cases. They know that often, if you're in a small practice in a small community, they know the family, they know what's going on. They can see if someone's behavior is different. So having that avenue for reception staff to give you the heads up to talk to you about that sort of stuff, it's another piece of the puzzle. It's really cool.
They often see more than the doctors, really, because they're observing them in the waiting room.
Way more, yeah, absolutely. So I don't know if anyone's got any.
There's a few comments in here. Offering empathy, compassion. I think a tellable person would give the impression they have plenty of time for them, even if it's not true. Can I just add that part too, because you GPs are so time poor. This is the beauty of this program, because they've disclosed to you, then you can pass them on over to me, and I can put them in, refer them to the appropriate services, or unpack it a little bit more.
Exactly. And we're going to talk about that right now.
Okay. Just a couple more. Sorry, Alison.
Oh,
yeah. They're interested and fully present, GPs, explaining confidentiality, being non-judgmental.
That's a big one.
Someone who is interested in the person, showing care.
You guys are all over it. That's
Chris
awesome.
has just said, I agree, my nursing staff are also invaluable for adding additional observation. The nursing staff are pretty imperative, aren't they?
Yeah.
Giving space to talk and validation.
All over it. Fantastic. So they're all of those things, and that's what, when working in this program, I've worked with a lot of victim survivors, survivor advocates that have talked about what they want from general practice, and you've basically just outlined all of the things. And so what I will say to you is, for you to reflect, how comfortable do you feel talking about sex? Because I sit in and watch a lot of registrars when in training, and you can just tell immediately in the room when they're not comfortable with something. It changes the mood in the room, and it changes the way that the patient responds and the things that the patient then tells the doctor. So starting to become more comfortable talking about sex, talking about relationships, I think is going to be really important. And that's something I can't change for you. That's for you to read and look at various things and feel more comfortable, because it's really important. So how can you ask? I'm going to skip through the case, unfortunately, because we're in the interest of time. I really like this kind of idea of, and you can use this with anyone. If the patient is just presenting differently or looks worried, or like, I can see that you look a bit worried today. Is there something you want to talk about, or is there something that you don't know how to start to talk about? Can be a really nice way of opening up, broad question about what they might be concerned about. If you're thinking more about screening things and talking to young people, particularly if you're doing contraception or sexual health screening or anything like that, this is a more direct question. And this would be a normalizing statement beforehand. Look, I ask all my patients this because, domestic family and sexual violence is common, but has anyone ever made you feel uncomfortable during sex? And you might just stop there, because I really like the word uncomfortable, because people in most cases won't self-identify that they experienced sexual violence or they experienced sexual assault or that they didn't consent, but they will be able to tell you that they felt really uncomfortable, and that might be the only thing that they can say. I felt really uncomfortable, but then they might try and justify it off. But the fact that they felt uncomfortable is the big thing. It means that they most likely did experience some kind of sexual violence. I don't like this statement, but it's from the White Book, which is why I put it in there. But again, a normalizing kind of screening question this might be for mental health, but it's really common for me to see patients who've had, a history of sexual violence or domestic violence that do experience ongoing stress or anxiety or depression. Is that something that's happened for you? Now, I feel like you'd really need to know the patient well to say something like that, rather than like a random out of the blue sort of a question. But that one is written in the White Book, which is why I put it there. And then this might be the really specific one, the presentation, the recurrent STIs, the big red flag for sexual violence or domestic violence. Like, when I see presentations like this, I do really want to worry if someone hurt you. And so that's, again, showing that care, trying to kind of see if you can get any more information. Now, again, someone doesn't want to disclose to you today, that's fine. You don't need to push them. Please don't push them to disclose to you. But you are opening the door and they might not tell you today, but they might come back next time and talk to you, or they might come back in 6 months or 12 months and talk to you about it. It just means that you've created that safety. You're a safe person to come back to later. So this is the case that I had for you guys, just to kind of give a little bit of context. So in this situation, Lily discloses to you that she was on a date with someone. She went online. She enjoyed the date, but in the end, she felt pressured into having sex with them in her home. So immediately you can well, that's not consent. And also she's worried because her date didn't use a condom despite her asking them to. So we've got kind of definite contact sexual violence there. And it happened 4 weeks ago. So there's things that we're going to jump into doing medically, and immediately your brain is like, oh, we'll need to do pregnancy, we'll need to do STI screening, we need to all of that thing. Great. But what is the one thing you need to say next? And that's what I'm going to teach you. This is the next thing you need to say. So one is just listen to the story. And the next thing is, I'm so sorry this happened to you. Thank you for telling me. That must have been really difficult. You didn't do anything wrong. This is not your fault. I believe you. Any of those statements are amazing. So just take a moment and listen to the story, and then say something very, very validating for the patient, because they will remember the thing that you say to them for probably the rest of their life. And this is the point in time where you have the ability to change that patient's long-term health outcomes. And the survivor advocates that we've spoken to, they talk about this all the time. If there's that first disclosure, if someone is very validating, very empathetic, caring, and tells them it wasn't their fault, and like that they believed, it kickstarts that healing journey for that patient immediately. And it decreases that long-term mental health, physical health, outcomes that we do see for people who experience sexual violence. So this, listening and you saying, thank you for telling me this is terrible. You didn't do anything wrong. This is not your fault. Absolutely, I believe you. What do you want to do next? That might be the most therapeutic thing that you do all day in general practice, or with your friend or family member. It might be the most therapeutic, the best thing that you do that week, month, 6 months, 12 months. And I know that sounds like a big claim, when we're picking up cancers and we're prescribing medication and we're doing other things medically, but this is why we're so great in general practice, because we do this so well. So if I can encourage you at any point, like if someone does disclose to you, like that's an amazing thing. You've done an amazing job. And then if you're able to provide that validation and that, again, you've done an amazing job and you're a fantastic GP or friend or family member. So if I can encourage you to do that, it seems so simple, but it has just the biggest long-term impact for people that experience sexual violence. Oh, and then don't follow up with a diminish or blame statement. So if you do want to get a little bit more information about what happened, don't focus on alcohol. Don't ask what were you wearing. Don't dwell on the party that they were at or whatever the situation. Don't dwell on any of that. Just get a couple of facts that are appropriate, and don't ever use the word, like the statement, at least, and then follow up with something, because that's very diminishing whatever has happened. At least they didn't do this, or at least it was only online and not in person, or like any of those. Always avoid saying at least, if I could say. Any questions about that?
Dimity has mentioned, I have found sexual violence disclosed by patients with recurring UTIs.
Yes,
which was spoken
absolutely.
about earlier.
Yeah, absolutely. So where do you go for help next? So the local sexual assault service for you guys on the Central Coast, we've had discussions with them. So they're really keen to see anyone under the age of 18 years. If they've had recent sexual violence in the last 14 days. Now, Georgia can also follow up with this, but generally that forensic window is about 5 days. And if you've ever referred someone to the sexual assault service, they don't sit in the waiting room within ED. There's like a separate space, and the clinicians get called in, and they write these amazing reports. They do all the forensic kind of photographs and tests and everything that needs to occur for that patient, and they write this amazing report. They'll call police in if the patient wants them, but if not, that information will stay there and be available to the patient if they do want to go to police in the future. And so, so in the last 14 days, that particularly after hours, you might be doing the on-call, and they might call a clinician in. Otherwise, it would be like a during the day kind of referral. And anyone that presents in crisis, because they can activate their social workers, their supports, they can get someone seen into psychology really quickly. So this is what the sexual assault service has said to us, that these are the sorts of patients that they're really keen to see, and to get seen by their service fairly quickly. I don't know if Georgia, you want to add anything to that?
That pretty much nails it. So so certainly in that, if it's been sort of within that 5 days, I'd get the patients to present to the emergency department, where they'll be seen by one of the sexual assault social workers, and they'll go through whether they just want a medical examination or a forensic examination as well. But that's where that time period is essential for collecting forensic samples. If it's been more like 10 to 14 days, that forensic period's probably lost. So they're probably better to come during the day hours when you've got the day staff, because after hours you've got social workers that might work in a different department in the hospital and not as experienced in sexual assault responses.
And always try and, if you're going to send someone to ED, call ahead to the service, and just let them know, so that person's not having to arrive in ED and tell their story to triage and all this kind of stuff as well, and send them with a letter so they can give, because you want to decrease the barriers as much as possible for that patient presenting to that service.
Yeah. And usually they're quite good, and they put them into the family room so they can wait for the social worker and the doctor to arrive.
Fabulous. I know I'm running out of time, but a local link. So if most of the patients that you see are not going to fall into that category where you're going to be referring to a sexual assault service, if you've seen someone that's presented weeks, months, years down the track, they're over age 18, or they don't want to be referred to the sexual assault service, they want advice and support, then this is where I'll be referring to our local link. So for sexual violence, all adult referrals must be with patient's consent. I can't stress that enough. So you must get the patient's consent and document that in your notes that they've given you consent to do a referral. Leanne, they can do some safety planning, risk assessment. Leanne also looks after domestic and family violence as well. And so they can provide telephone advice and support to you, the clinician, as well. They can support them going to police, and you also get feedback back to you about the outcome of the referral that you make to our link. Now, for you guys, it's Leanne Fletcher. So I don't know, Leanne, in 2 minutes, if you want to quickly. I'm sorry, I'm running late.
That's fine. Yeah. So yes, like Alison said, I'm the local link, and like Alison said, I'm just repeating what Alison said. I can support you guys too. But the only referral pathway is from, they can't self-refer. The patient needs to be referred by you guys. So that's you can't kind of just hand our number out to the patients, unfortunately.
Yeah, so please, that mobile number is for clinician use only. Don't give that to the patient. So Leanne works for Relationships Australia, so they've got all that additional kind of backing and support from that big organisation as well.
And actually, our counsellors, they generally have a long wait list. Actually, at the moment, there's no wait list. So if there's any disclosures, refer them on, and we can get things happening. Yeah. I'd actually love to have the opportunity to come and visit your practice, to put a face to the name, and introduce myself, give you some resources.
And so I know time is up, so I'm not going to have a chance to go through the rest of the kind of stuff that I wanted to talk to you guys about. But we will come and do this training for you and the whole practice at a time that suits you. So if you're keen for us to come into your practice, and I believe that this presentation can be for anyone. So for your reception, for your nursing, allied health, the clinicians, anyone who wants to hear, we're very happy to educate them. And so we'll do this session at a time that suits you. We can have more case discussion. We can talk about practice-specific issues, and we can support you guys as well. So if you would like us to come, please get in touch, either with Leanne, we can follow up with the practice, and we'll go. And this kind of recording stuff is really important, and I don't have time to go through it now, but this is something that we will come and talk to you guys about in the practice.
We're getting great. Sorry, Alison. We're getting great feedback from the training, so I think it's really beneficial.
And so if you've already done the domestic and family violence training, we can do it again for you in practice because things have changed a little bit. We offer 4 one-hour sessions, so we can come at lunchtime or before and after work. Domestic family violence, sexual violence, child sexual abuse, and an applied practice session where we will do case studies and chat to you and what would you do in this scenario kind of thing. Or we can do 3 hour-and-a-half sessions if you prefer for us to do a little bit longer, which I think is better, but it just depends on your practice. Very, very quickly, if you haven't heard of the SARO, I would type that into Google and have a little bit of a look. That's for people that don't feel like they want to go to police and make a statement, but they want to document what happened to them. They can do that online, and so our links can help support that, or refer them to the social worker or for counselling to help them do that option. It doesn't generate an investigation, but they can put the perpetrator's name down, and if another report is made about the same perpetrator, the police can then get it back in touch with that person and ask them if they'd like to make a formal statement. So that's a brand new thing that's come out. Victim services counselling is also available to people, and health pathways. So you've got health pathways as well, which has a lot of this information and the link contacts and all that kind of stuff as well. So if you're looking for information later, please have a look. I'll make these slides available to you guys as well. And self-care is important. So these are some of the other lines. If you've got someone that doesn't want to be referred to anyone yet, but you want to give them a number, you can give them that New South Wales Sexual Violence Helpline. Full Stop Australia is another really good one that you might give the patient if they're not wanting to be referred just yet. But our links are amazing. Leanne is fabulous, and so if the patient is keen and for that ongoing support, I would really strongly recommend doing referrals to the link or just calling for advice. You can de-identify and just go, what should I say? What should I do? They're very happy to do that as well. If you want to scan the QR code, that one comes back to us at the PHN, and you can put some comments. If you want us to come to your practice, put your practice name in there. and then we can get in contact with your practice and come and do more education if you're keen. But over time, so I will finish there. And I think, oops, I'll go back to that, give you a moment just to scan the QR code. But is there any comments, questions, anything in the chat, or anyone wants to unmute their mic and ask anything? I'm very happy for you to do so.
There was a couple more comments. I didn't know if we had time to mention them. Just all Gordon's mentioned. I also thank them for the courage of disclosing.
Yep.
Yeah. So yeah.
No, thank you, Alison. It was a fantastic session. Obviously, a huge topic. So we need to come back again, but no, certainly, you know, it will have opened everyone's eyes. Again, another reminder, because we see so many patients with, you know, those risk factors, so either vulnerable populations, those with mental health issues, or those gut and pelvic pain issues as well. So we just need to be, obviously, you know, providing a supportive environment so patients feel that they can disclose, and we now know where to refer them to. So thank you so much.
Yeah. And please use the LINK program. Like I said, we've only got funding for another 12 months, and we're pushing really hard to get that extended because the program has been so fantastic. And the GPs that have used it are like, oh, it's like the advice and support and knowing our patients are looked after, and especially with from a domestic family violence and safety perspective, like it's really, really great. So very happy to chat to anyone further about it if you'd like to.
I'd love to come out and even introduce myself to the receptionist and all of the staff, you know, just so you guys know I'm here.
That's awesome. I'm sure many of the practices here will take up on that offer, Leanne. Right. So thank you. But I'll hand over to Sydney. So, and don't forget, there's another QR code for the evaluation. But I'll hand you over to Sydney, and we'll see you for our next session in 2 weeks' time.
Thank you.
Thank you, Alison. Thank you, Leanne. Going to hit stop.